Hi, my name is Richard Corcoran, and I'm a student in the Master's of Social Work program at the University of North Carolina at Pembroke. I'm going to talk to you a little bit today about cognitive theory. Cognitive theory is the theory behind one of the most commonly used and important types of psychotherapy in use today, which is cognitive behavioral therapy. Cognitive behavioral therapy, as the name implies, also includes techniques derived from behavioral therapy, but most cognitive behavioral therapists would agree that thought or cognition precedes action. So most of the emphasis on this type of therapy is on the thinking process behind the behavior. One of the predecessors to cognitive behavioral therapy was Albert Ellis, and he believed that behind people's dysfunctional behavior lay irrational beliefs, and that these could be changed through persuasion. And also Aaron Beck, who was a psychoanalyst, who had been having trouble treating people with depression. This was before it was known that depression can be a genetic or brain chemistry, physical disease, and he wasn't happy with the way psychoanalysis addressed depression, so he began working on cognitive attempts to address depression, which focused on changing false or irrational beliefs that people had and seeing if through a collaborative approach with those clients, he could help them to overcome the beliefs that underlie their depression. So cognitive behavioral therapy is used in a wide range of interventions today, anything from smoking cessation programs to weight loss programs to being used for people with anxiety disorders, major depressive disorder, post-traumatic stress disorder, which cognitive behavioral therapies have proven to be one of the most effective ways of treating. So I'm going to talk a little bit about what this cognitive theory, which is behind these therapies, believes, and what are the major concepts and some of the major interventions and processes that this theory is based on. So one of the most basic concepts of cognitive theory is schemas. And a schema is a group of ideas centered around a basic idea. For example, everyone has a concept of a mother, and most people have a concept of a good mother, or likewise a good father. So we would think a good father would probably be someone who cared for his children, a good provider. Maybe for some people, a good father would be someone who provided discipline to his children. So there's a lot of specific ideas that we've developed around our personal idea of a good father. And that's a schema. A schema can be bigger than that or smaller than that. For example, you can have a schema about the world in general. Is the world a safe place or a unsafe place? Are people good and decent and helpful, or are people dangerous and are people to be frightened of or concerned that people will not treat you well? So around a certain concept, whatever that concept may be, we have these surrounding ideas, and they usually come from our experience, and they may be pertinent to various experiences that we've had, and they may develop or build up over time. So when we are adding something new to these schemas, for example, our idea of a good father, if we see a father doing something we haven't seen a father do before, like take his daughter shopping for a prom dress, and you think that's usually something a mother does, you might assimilate that idea into your idea of a good father. If you see a father who doesn't fit your schema. For example, you've always thought a father should be a good provider, and you meet a father who's basically a house husband and his wife earns all the income. You could accommodate your idea of a good father to say this is still a good father even though he does not provide an income for his family. So within these schemas, or even as a result of these schemas, we all experience what are called cognitive distortions. And cognitive distortions are basically errors that get into our thinking. They are sometimes called cognitive errors or cognitive distortions. So a cognitive distortion is where, and it happens to everybody, is where we have developed an idea or become sure that an idea is a working idea when in fact it's not. And it's important to remember that these are not necessarily, when we say it's an error, it isn't about whether the idea is correct or incorrect, but whether or not it interferes with our functioning. And we can have some cognitive distortions without upsetting our functioning, and everybody does have these to some degree. So some of the most common cognitive distortions are, one would be what's called arbitrary inference, where based on something that happens that really has nothing to do with what you think it has to do with, you come up with an arbitrary inference that, for example, because I had an accident on the way home from the grocery store, it's probably dangerous to go to the grocery store. Another example would be minimization or maximization, where one event happens which you blow out of proportion. For example, getting a bad grade on a test. You get a bad grade on a test and you think, I'll never be able to pass this class. Another is overgeneralization, which is where we have one event happen to us and we just generalize from that to a lot of other events. For example, I was bitten by a dog as a child, therefore I believe that all dogs are dangerous and I could possibly be bitten by any dog that I meet. So the purpose of an intervention in cognitive behavioral therapy is to help a person to resolve these cognitive distortions through a process that's called cognitive reprocessing. This is one of the main methods or types of intervention in cognitive behavioral therapy. And typically, cognitive behavioral therapy is an active collaboration between the therapist and the client. The therapist is actively involved in several different roles, both as a educator, educating the client about the type of therapy, the purpose and reasoning behind it, and also helping the client to identify cognitive distortions, cognitive errors, and give them the tools to help them process and resolve those. It's typically a highly structured therapy, often manualized, most often manualized, and there will usually be a specific number of sessions leading to resolution of the specific presenting problem. Assessment is based on what's called a Socratic questioning method, and that refers to the Socratic dialogues of Plato from ancient Greece. And what that is based on is focus questioning, which helps the client to begin to come up with the answers on their own. In other words, the therapist is not providing the client with answers, but they're asking the right questions to get the client to think about and reformulate the way that they think about a problem. The assessment is trying to get at what's behind the thought process, what's the logic behind the way the client is thinking, what are some of the core beliefs or schemas like I spoke about earlier, which are informing their view of the world or their view of the problem or the situation. So within cognitive restructuring, there's what is called the ABC model. And A stands for an activating event, B stands for a belief or thought about the event, and C stands for consequence of that belief or thought. From our earlier example, when the person was bitten by a dog as a child, now whenever they see a dog, seeing the dog is an activating event, the belief would be all dogs are dangerous, I'm afraid of dogs, and the consequence might be that they run from dogs or avoid dogs or maybe don't even go outside because they're afraid of dogs. Within the cognitive behavioral therapy, after establishing what the cognitive error and the process behind the thought within this ABC process, the therapist would provide the client with homework which would allow them to do an ABC review. And an ABC review encourages the client to recognize that thought process as it's happening and then to try to replace the cognitive error with a alternative belief or thought. For example, they may still have the belief, oh, all dogs are dangerous and therefore I'm afraid of dogs, which is the consequence, but they can start practicing to replace the cognitive error, in this case is overgeneralization, with a more functional thought process, for example, and more in line with reality. They might say to themselves, well, all dogs are not dangerous. Most dogs don't bite. And they can record for themselves, this may be after the event, if I were thinking all dogs are not dangerous and most dogs don't bite, what would be the alternative consequence? The alternative consequence would be I wouldn't be afraid of all dogs. I wouldn't be afraid to go outside if there are dogs in my neighborhood, etc. There are other types of cognitive therapy. One is called cognitive coping, and this helps people who may not have basically lost some functioning because of their cognitive distortions, but are still having trouble dealing with stress or life situations. And it also works on modifying distortions, maybe in habits of thinking where people are just used to thinking in a certain way about a certain problem. For example, when I feel stressed, and that may be based on experience, when I feel stressed, it helps me to have a few beers when I get home, and that relieves my stress. And this has become such an ingrained habit of thought that they really can't relax without having a couple of beers because it's become a ingrained habit to think that that's the only way to relieve stress. Another process that cognitive behavioral therapy works on is building communication skills. And this focuses on what's called reflective listening, where you basically repeat back or summarize or paraphrase what the person has said to you when you're having a conversation with someone to make sure that you're understanding what they're saying. And in your response, you use I statements where you, instead of accusing the other person, you say, I feel bad when you're angry at me, rather than you make me feel bad. You talk about what's happening with you rather than accusing the other person or blaming the other person for how you feel. You just describe your feelings or your reaction to whatever they're saying. There's also a type of cognitive behavioral therapy that's just called problem solving. And this involves identifying what a problem is, brainstorming some ways to resolve that or address it, and then evaluating alternatives to the thinking that underlies the problem. So these are some of the major concepts behind cognitive theory and incorporated into cognitive behavioral therapy. And one of the benefits of cognitive behavioral therapy for use in practice is that in many different areas, from anxiety to depression to PTSD to smoking cessation to weight loss. These therapies have been tested, and there's a lot of evidence to show that they are supported by the evidence. Perhaps one of the drawbacks with the theory is that it's very present-centered, so there's very little attention paid to, say, deep-seated childhood issues, and it may be particularly unsuited for problems that are rooted in the unconscious mind, perhaps problems that someone doesn't remember, for example, having been sexually abused before they could remember that. Or on the other hand, it's not particularly useful for young children or people with various significant intellectual deficits or dementia who can't really follow the cognitive processing or reprocessing process, because you have to be cognitively competent in order to be able to follow those steps and reprocess your cognitive beliefs. So, to summarize, cognitive behavioral therapy is widely used, widely practiced, and in many instances is one of the best evidence-based practices for resolving psychological issues. So for most therapists today, it's something that is at least incorporated into their practice, and for many, it is one of the most important tools in their practice. Hi, Ms. Rex. How are you today?
I'm good.
Hey, I'm Richard Corcoran. I'm one of the therapists here. Thank you for coming to see me. Come on in and have a seat.
Thank you.
So, I'd like to start just by telling you a little bit about what we're going to do today. You talked to me a little bit about over the phone about what what kind of problem you're having right now. So, I want to just kind of see how you're feeling. Then we'll talk a little bit more in depth about what's going on, and I'm going to try to give you some options for how we can address that and tell you a little bit about the type of therapy that we do here. Okay. So, just to kind of get a check on where you're feeling right now, how would you say on a scale of like 1 to 10 what your, comfort level or mood is right now?
4.
Okay. So I take it from that you're not feeling really great or not really like yourself. What would you say would be a number you'd be more comfortable at between 1 and 10, that where you would feel just normal and comfortable?
Maybe 7 or 8.
Okay. Thank you. So you talked to me a little bit about on the phone about some of the symptoms you're having, and that these came after you got back from a recent tour of duty in Afghanistan. Could you just tell me a little bit more about that?
I really don't like to talk about it. I just don't like to talk about it.
And I can understand it was probably pretty disturbing stuff, but could you just tell me, maybe not in detail, but just give me a little bit of information about some of the things that happened and some of the symptoms you're having since you got back?
Well, I was over there for about 15 months, and during that time, I lost a lot of people. Almost everybody that I went in with, they were here 1 second, and the next thing I know, they were gone.
I'm sorry to hear that. What type of situations? What happened?
Roadside bombs, anything you can think of.
Okay. So that happened while you were in Afghanistan, and then just tell me a little bit more again about that, like you did on the phone, about what type of problems you've had since you got back from that tour of duty.
Since I've been back, I thought, first couple of weeks, I assumed they would be hard because, my previous deployments, I came back couple weeks and I was back to normal, but this time it's different. I, I can't relax. I don't sleep. I can't get comfortable. I don't enjoy things, and it's like I'm terrified of everything.
Is there anything specific that you're afraid of? Like, anything that you would say sets off that feeling?
I know that driving is torture.
Okay.
I pretty much have to just keep myself calm when I'm driving somewhere, or if I know that it's across town or long distances or things like that, I make somebody else drive. I just ask somebody else if they'll drive because I can't do it. I just can't.
I understand. So, and you mentioned to me on the phone that you had been a medic over there, so you weren't directly engaged in combat, but you were on some convoys with people, and you obviously saw some people who were severely injured in your job. And so I was thinking, from what you had told me, both on the phone and now, that some of the goals that you might want to set, and you can certainly, I want this to be a process where we do this together, but, some things that you might want to see some improvement on would be being able to drive without being afraid, being able to sleep normally,
Yes.
and just being more comfortable in public situations than you have been so far since you've been back. Can you tell me a little bit more about what you would expect out of therapy, or what you're hoping to gain from it?
Pretty much everything you said. My biggest concern, like I said, is the driving. I have family that I want to go see because I still haven't seen them since I, came back. My family's busy. They can't drive me around all the time, so I pretty much just stay at home and where I feel safe. I really don't feel safe in that many places.
Okay. Well, let me tell you a little bit about the type of therapy we do here. It's called cognitive behavioral therapy. And the premise behind it is basically that we have a thought process behind, these fears and the type of symptoms that you're having. That something caused you to not feel safe, which I would say would be, the time you spent in Afghanistan and the traumatic experiences that you suffered there. And would you say that when you were a child, for example, or before you joined the services, did you feel safe and comfortable in public? You felt safe driving and that type of thing?
Of course, I was your average, young girl.
Right.
If I wanted to, I had to get in the car, head to the beach with my friends, or just very free spirited, just felt confident and safe. I was fine.
Okay, so I would say that what happened was a change in your view of the world. Like before you went to Afghanistan, you felt the world was a safe place, and since you've come back, you just don't feel that anymore. Even though nothing like that ever happened to you here, you still feel like when you're driving, it's not safe because you've seen vehicles blown up in convoys, and you're just not safe in public spaces where you feel exposed. So what this type of therapy would help you to do is kind of reprocess that information, reprogram those thought patterns so that you can have a more realistic view of how safe you are or not. I mean, anytime, I would say that anytime any of us get on the road, we're taking a risk, but it's not the same kind of, major risk that you would have been taking when you got on the road in a convoy in Afghanistan. Would you agree in theory that that's probably true?
Yes.
Yeah. So I think what our type of therapy would suggest is that you can change that way of thinking. It may feel unconscious, but a lot of it is based on actual experiences that you had and kind of thought processes that has set up in you. Just like, for example, if I was bitten by a dog as a kid, I might have been afraid of dogs for a while after that, even though it was only one dog that bit me. So I'm going to suggest a type of therapy It's a very structured therapy called prolonged exposure. And I know you said you don't like talking about, the traumatic stuff that you went through, but this type of therapy, it's over 12 sessions, and it does require you to talk about that stuff in detail. I know the reason a lot of people don't like to talk in detail is because they're worried that it's going to bring back memories and make it harder. But this type of therapy has been proven pretty effective if you go through that and you're willing to talk through it with the help of a therapist and kind of pinpoint where those thinking patterns changed. It's had a very good success rate. So even though you don't like to talk about it, would you be willing to if you knew that that was going to help you affect change?
At this point, I just need some comfort. I need some relief. So,
Okay.
Yeah, I think I can.
Okay. Well, I'd like you to just do one thing. We're going to set that first session for that up next week. But in the meantime, I'd just like you to kind of keep a log of times when you start to feel very anxious, whether it's driving, being out in public, and if you would keep a log of the nights that you have difficulty sleeping, and if you have any, this is a generalized thing just to get started with. We'll do some more detailed homework, so to speak, as we go through the more structured sessions. But this will help us to just get an understanding of when these more anxious moments occur. Does that sound like a decent start?
I think so. Yeah.
Okay. So basically, after kind of talking about what your problem is, we've kind of decided on at least a path towards a solution. Do you feel comfortable with that? Do you feel like this was a good choice to attempt at least?
I think so. Overall, I think it'll help.
Okay.
I just
Well, I'll be happy to, break it for good. So I'll take it out and skip. Reviewing this training video, the therapy session of the training video, we can see one of the common mistakes or criticisms of cognitive behavioral therapy. While the therapist in the training module video does hit some of the main points that are important for a first session, for example, setting an agenda, checking the client's mood, getting to the some information about the presenting problem, setting goals, getting the client's expectations, and educating the client about the problem and the type of therapy, as well as giving the client some homework to do and summarizing the session for the client. There's one criticism of cognitive behavioral therapy that says because it is often so structured that the therapist can get too involved in the nuts and bolts, the actual structure of the therapy, and not be as aware of the client or as empathetic with the client. And in this case, that seems to be the case. The therapist, who's not very well trained, is more interested in kind of hitting those high points, the main points that are important for the session, but misses several opportunities to validate the client's experience when she talks about her experience in Afghanistan and the losses that she suffered. The therapist looks empathetic and says, I'm sorry to hear that, but there's a lot of places where the therapist could have been more validating and helped build the client-therapist relationship by really saying to the client, wow, that had to have been very traumatic. That must be difficult to have lost so many people who were close to you. That must have been a terrible experience. It must be difficult not to be able to drive and see the people that you love after being gone so long. So there were many instances when the therapist could have used some reflective listening, kind of reflecting back to the client what they had said, and also showing more verbal empathy and validation of what the client had been through. So it was a short session, and the client is agreed to come back for further sessions. So hopefully in future sessions the therapist will take more time to build that client-therapist relationship before launching into the actual process.